The aponeuroses, I'll show you a little bit later on. Aponeuroses is a large, flat sheet of tendons that gives muscle a place to attach. So we'll see that in areas like the abdomen and on the scalp, on the cranium. Mostly where there's flat areas and you have to have muscle attaching to something. And then they end up pulling against one another, which works out well. The retinaculum, I already talked about that. So if you continue on to this next bit of information, you will notice the names of muscles are in Latin, which scares people, because then they think, oh no, now I have to learn Latin. Understand that, remember, they try to make this easy for you. They really, well, at least easy for themselves. So if you look at the name of a muscle, like the flexor hallucis brevis, what is the hallux? So we know that this is a muscle that has something to do with the big toe. Does it flex it or extend it?
Flex it.
It flexes it, which means it's going to I'm not going to take my shoe, I'll show you my toe, but it's going to do something like this as compared to something like this. This is flexing, this is extending. So now we know that this muscle is a muscle that flexes the big toe. Now, is it a short muscle or a long muscle? The word brevis, brevity, means short. So what they're telling you here is it's a short muscle that flexes the big toe. That's all it is. It's very simple, if you speak Latin. To them, it made sense. But you learn more from this. Because we know for all these muscles that do something, there's going to be a muscle that does the opposite. So if this is a muscle that flexes the big toe, then there must be a muscle that will put it back. So there's got to be something called an extensor muscle, like a extensor hallucis muscle, and that would make sense. But we also know something else. If we call this flexor hallucis brevis the short muscle that flexes the big toe, then there must be a long muscle. Otherwise, we wouldn't have called it the short muscle. Right? So you would think there must be a flexor hallucis longus. And if you look, you'll find it. So it really does make sense when they name these things, if you speak Latin. Did everyone sign in? Yes, no, okay. The movements. If you have your textbook in front of you, I think it's page 170. Let me see if that looks right.
It is.
It is?
Yes.
Thank you. Page 170. About 173, I think. We see these different movements here. You're going to want to know these movements. You don't have to know all the ones in the book if you don't want to. Although I think I've listed most of them, there's just a couple. But I definitely recommend you know the ones that I've listed here for you. The first two, flexion and extension. An example of flexion would be something like this, or something like this, or something like this. Extension would be like this, or like this. Now you'll notice with flexion I have including dorsiflexion and plantar flexion. In this case we're talking about the toes, and you can see that on bottom page 171. Dorsiflexion and plantar flexion. Dorsiflexion, the toes go up like this, Plantar flexion, the toes point down towards the plants. That's how I used to remember it. So if I was sitting on a table like this, bless you, excuse me. If I'm sitting on a table like this, my toes pointing up like this, or dorsiflexion, my toes pointing down like this towards the plants is plantar flexion. But don't get confused, because if I'm standing here and I plantar flex my foot, what actually happens is it picks my heels up off the ground. Standing on my tippy toes. Does that make sense? Plantar flexing the feet. I don't want you to get confused. You say, but if you look at the foot, the toes are bent like this. Well, that's just because the floor can't get pushed. I can't push the floor down. So plantar flexion, the toes are going this way. Dorsiflexion, the toes are going this way. Good? No? Yes? Okay. Abduction and adduction. You'll hear me use say it this way. I'll say abduction and adduction because abduction and adduction sound so similar. I want to make sure that people can hear me as clearly as possible. So I'll say abduction and adduction. Abduction is moving a body part away from the midline. Abduction is moving a body part away from the midline. Abduction is moving a body part away from the midline. Adduction is moving a body part toward the midline. Adduction, moving the body part toward the midline. Adduction, moving the body part toward the midline. Or as I like to say, it's adding them toward the midline. Adduction is moving them toward the midline. Abduction, like an abduction, like taking someone away, yes. I wasn't going something quite as violent, but rotation, this one's pretty simple, right? Do you know an example? No? You don't know an example? No? Really? No? You don't know any? I know. This is for the people who are looking up. Easy, rotation. Supination and pronation. The hands. Supination, supination, pronation, pronation. 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 This is concerning the hands. Supination, supination, pronation, pronation.
All right.
The last one, eversion and inversion. Here we're talking about the foot. Again, you can see this on the bottom page of 171. Eversion and inversion. Eversion is going to put the big toe, the hallux, on the floor. It goes like this. Eversion is going to put the hallux on the floor. It goes like this. Eversion is going to put the hallux on the floor. It goes like this. Now, you can imagine what happens if somebody jumps off of a roof. Comes down, their foot goes like this. Well, they might break their ankle, true. But what also happens, it causes this fibula, remember the fibula, to get pushed up. And remember, the fibula articulates with the top of the tibia. So the fibula gets pushed up, snaps off, and comes through the skin right about here. Causes a proximal fracture of the fibula. And we saw this in a basketball player, a college basketball player a few years ago. Came down on his foot this way. And this was the skeleton. I noticed when I came in, there were a lot of people this morning going through the bones with back. Actually, there was no one, come to think of it, going through the bones here. I strongly recommend that you do that. Remember, I will be here tomorrow from 11 to 1. If anyone's interested, stop by, or I know there's people who are stopping by, so that's why I know for sure I will be here from 11 to 1. We'll have an opportunity to look at the bones again, for instance, maybe some of these other things that we didn't get to see in the skin section, or we can't finish up today, because we have a lot to get through. We are going to start, excuse me, we're going to start with the muscles. Sound like I'm ordering a Red Lobster. We're good. Back call. going to start talking about muscle. What do muscles do? Not much. Movement. And how do they cause movement? They contract. And what is a muscle contraction? That is when a muscle shortens. And realize, please look up here, I'm explaining something that they're not going to tell you in the book. When a muscle is connected, it is connected at two ends, at least. So when that muscle contracts, it shortens. That's going to pull these ends closer to one another. That's all a muscle does, but that's how it causes movement, because now we have something moving. And you'll notice I drew one sort of moving more than the other. We'll see that in just a little bit. And then what happens to all this extra muscle that's in here? Where did it go? What's it do?
It's bunched up.
It gets bunched up. That's why the muscle looks like this. It goes from being a long muscle to a big bunched up ball muscle here. This is such a simple concept, what muscles do. All they do is they become shorter. And we call that a contraction. Well, that's what happens during a contraction. And you can see it here as a linear, very straight muscle, very easy. So imagine what would happen if I have muscles that are sort of wrapped in a circle like this. Connected here, connected here, connected here. When this muscle shortens, what's going to happen to it? I know, when this muscle shortens, what's going to happen to it? It's going to pull these two ends closer to one another, right? And when this muscle here shortens, it's going to pull these two closer to one another. When this muscle here shortens, it's going to pull these two closer together. So then you get an effect like this happening. This is important to realize because we're going to talk a lot about muscle inside of walls. We're going to have tubes. They're going to have muscle inside of the wall of that tube, just like this. And when that muscle contracts, the opening is going to become smaller. Where that muscle relaxes, it's going to become bigger. So it's an important concept. It's very, very simple, or at least simplified here. They don't go into this in the textbook. They don't tell you like this. And I don't know why, because it's a very easy way to describe it. But they always want to seem to make it more complicated than it is. Now, well, I should say that. It does get complicated. We are going to see some of the physiology of it. And it's just going to be a brief overview of the physiology. But it will get a little more complicated. However, there is a way to explain this that makes it easier. And I wish that people spent more time writing books that made it easier. Well, at least that's what I'm here for, right? All right, the musculoskeletal system, if you happen to have the notes in front of you, page 46. You don't need these notes. These notes are not required for the course. They're merely offered as a convenience. I'm talking to the camera now. I want to make sure that's on record. Muscles cause movement, that's what they do. We have over 700 in our body. We are not going to learn 700 muscles today. So relax. You're welcome. Actually, it's my decision. Very simple definition here, musculature. The group of muscles associated with a particular area of the body. And you can understand that, because you can realize that there's going to be more than one muscle associated with the shoulder, for instance. So we call that the musculature of the shoulder. Or because we have so many things that our hand does, so many different movements that our hands do, there has to be more than one muscle that does this. So we say the musculature of the hand. Does that make sense?
Yeah.
Okay. Did you sign in? Did anyone not sign in? Three types of muscle in the body. Skeletal muscle, cardiac muscle, and smooth muscle. Well, first of all, I think you can kind of figure out where cardiac muscle is going to be found, right? Skeletal muscle is going to be somehow associated with the skeleton. It's the muscle that's going to move the skeleton around. It's the muscle that you think of when you think of somebody having big muscles. When you tell somebody to make a muscle, that's the muscle. That's the type of muscle we're talking about. And for this chapter, that's the one we're going to be discussing mainly: skeletal muscle. Skeletal muscle is under conscious control. If I want to lift my leg like this, I can do that. I can think about it. Lift my leg, move my leg, lift my arm, flex my fingers, flex my arm. Skeletal muscle is under conscious control. It's the only one of these three that is under conscious control, so that makes it easy to remember. Skeletal muscle is striated. When you look at it under a microscope, the cells have little stripes going across it. Bless you. It is what we call striated. It has these stripes. And that's the result of components of the muscle cells that are somewhat visible under a microscope. And it is not surprisingly all lined in the same direction, which makes sense that all the muscle of the bicep here is all going this way. So when part of it contracts, it all contracts in the same direction, all causing the arm to move up like this. Cardiac muscle is involuntary. You don't have to think about it, thankfully. You don't have to think, oh, gotta make my heart beat. Oh, gotta make my heart beat. Oh, gotta make my heart beat. Every 0.8 of a second. It is involuntary, thankfully. You don't have to think about it. Cardiac muscle also has those little striations, those stripes going across it. And cardiac muscle is a branched muscle cell. And that makes signaling very simple. Makes it easy to conduct a signal from one cell to the next when it has these branches off of it, so that all the cells in that area get the signal to contract at the same time. And that's what they do, causing that heart to contract, causing those ventricles to pump the blood out, for instance. Smooth muscle is an involuntary muscle. Just like cardiac muscle, you don't have to think about it. Smooth muscle is what we're going to find inside of the walls of those tubes. Smooth muscle, when you look at it under a microscope, does not have striations. It does not have stripes. So it looks smooth. Again, you see, medicine is really not that difficult. They name things, trying to keep it fairly simple. Smooth muscle is going to be found in places like the urinary system, in those ureters, for instance, to push the urine down. It's going to be found in the fallopian tubes, one of the things that helps to move the ovum, the egg, from here to there. It's going to definitely be found in our arteries. That's what's going to help pump blood through the body. Although the heart does a good job of pumping blood, it does not do it alone. The arteries in our body have this smooth muscle that can relax as the blood comes through and then contract. And that helps to push that blood in a unidirectional flow, in a one-way direction. We'll find it in the gastrointestinal system. It will help move that food or food products all through that tube in our body so that we can break down, absorb, and then get rid of the stuff that we need or do not need, as the case may be. Even in the respiratory center, it's going to allow for those tubes to bring air more or less into the body. Okay. So if we look at a muscle, the belly of the muscle is where the most mass is located. And then we'll find that it is going to have at least 2 points where it's connected, and I'm using bones to make it simple. And then we have a tendon that attaches the muscle to the bone. The muscle does not attach directly to the bone. The bone attaches to the tendon that attaches to the muscle that attaches to the bone, which is why we see there's bone, tendon, muscle, tendon, bone. Bone, tendon, muscle, tendon, bone. Bone, tendon, muscle, tendon, bone. This way, if you get confused about ligaments. We learned about those on Tuesday. Ligaments are going to link bones together to keep them in alignment. Here we will see that we have the tendon attaching to the muscle, tendon attaching to the bone. So if you remember that it goes bone, tendon, muscle, tendon, bone, you'll remember that it's the tendon that attaches here. So it must be the ligament that attaches like here to here. Bone to bone. We have a covering from the continuous tendon around the muscle. Called fascia. That's going to help keep everything tightly together. We have a place where the muscle starts. That is called the origin. This is where it starts. And then we have an insertion. This is where it ends. And that's really determined by which part moves more, which part moves less. So that when this muscle contracts, this one will move, might move a little bit this way, this end moves more that way. So that's how we determine the start of the muscle versus the end of the muscle, the origin versus the insertion. And the muscle will cross a joint. So let's see, if we have an elbow joint, bicep muscle starts up here, crosses over that joint, attaches, inserts down on the radius muscle, or radius bone. When this muscle contracts, it's going to shorten. It's going to pull these two areas closer to one another. So it's going to take these points closer to one another. This is a hinge, so that's going to cause this to move up this way. Something like this. And you see what we did? We changed the angle of this joint right here. We went from being 180 degrees to 90. And we can even do it some more to make it 45 degrees if we wanted to. So we're going to change the angle of the joint when that muscle does contract. Bless you.
So the muscle,
Yes.
so the muscle, you're saying that the muscle crosses over the joint. So it's really here? It starts
Yes.
here?
Yes.
Okay.
Because if it was here, if it stopped right here, it started right here, when it contracted, it would just do this, but nothing would move.
Okay.
The reason the muscle is there is for movement. So it actually comes down and attaches on this bump right here in the radius.
Okay.
So that when the muscle contracts, it starts two places actually, up here, here, and here. Stretches down this way. When that muscle contracts, this area moves less, this area moves more. The arm moves up like this.
When you move down, it's the opposite?
That's because we have a muscle over here, which I'm going to get to right now, attached here, here, and here, over to here. I'm running out of place to put my fingers. So when that muscle contracts, it pulls the arm this way. Which is a good thing to remember. A good way, in fact, to remember muscles is to group them together. For every muscle in the body, for the most part, there's going to be a muscle, the skeletal muscle. There's going to be a muscle that does the opposite. My arm's like this. I have my bicep muscle that pulls the arm up this way. I don't want to walk through the rest of my life like this. I look foolish. So I want to have a muscle that's going to put it back to where it started. And that's what the tricep muscle is for. So when the tricep muscle contracts, it pulls the arm back this way. Now understand, when one of these muscles contracts, the other one has to relax. Otherwise, they'd just be pulling against each other and nothing would happen. Does that make sense?
Yeah.
And if you look at our fingers, for instance, disregard the thumb for now, just take a look at the fingers. If you look at the fingers, when they flex, when they get pulled this way, where are those muscles located?
This one here.
Just like this. All we're doing is pulling them down. These muscles are actually located here.
Oh, wow. You can see it.
But the tendons are long, and the tendons actually run all the way up here, across here, right through here, and up the tip to this finger. So when this muscle contracts, it pulls the finger down this way. When these muscles contract, they pull the fingers down this way. Which means they're going to have to be muscles that are going to do the opposite. Where do you think they're going to be found? So when they contract, they pull the fingers up like this. Or just one finger like this. You know, I was going to do that. One. So that makes it easy, actually, to remember the names of all these muscles. It makes it easier to pair them up. The muscle or group of muscles that does this versus the group of muscles that does this. Now, I saw somebody do, what about the muscles in between here? There are muscles in between here that pull the fingers this way, and there are other muscles that pull this way. There are muscles here and here that pull, that help to pull the thumb across this way. And in fact, if you flex your wrist a little bit, this is flexing, this is extending. So if you flex your wrist, that's like this way, and you touch the tip of your thumb to the tip of your pinky, you'll notice one of these tendons will pop up right here. This is called the palmaris longus. You don't have to do this if you don't want to, but I'm just saying everyone else is. So, everyone else is cool, and maybe you're not. I don't know that for sure, but we're all doing this. So if you look right here, this is called the palmaris longus. This is one of the tendons that runs up through here. Why don't we see the other ones?
Because they're behind it. And they're not flexed.
They're actually underneath a binding around our wrists and around our ankles as well, called the retinaculum. The retinaculum is, my friend used to call it God's bracelet. Because what happens is, as we flex these muscles and those ligaments, those tendons that run all the way up through here and up to the tips of the fingers, those tendons would pop out, which would make our strength, our grip, a lot weaker. So we have to have something to hold them all in place. This is the only one that is not underneath the retinaculum, the palmaris longus. All the other ones are underneath to make sure that they have the strength that they need. Okay, fascia, I already talked a little bit about that. It's continuous with the tendon, wraps around the muscle, helps to keep everything together. A bursa, we saw that a little bit in the video on Tuesday. A bursa is going to be found in areas that's going to be like a pocket of fluid. I think we saw it around the shoulder, actually, in one video. That's going to decrease the friction in that area. This is why you see somebody who comes out like this suddenly grab their leg here. And you think, their first thought is they probably broke their ankle, but they grabbed their leg here because they have bones sticking out. Yeah, that's good. I know. Inversion puts the pinky toe on the floor. Inversion puts the pinky toe on the floor. Inversion puts the pinky toe on the floor. So, I always say this is like when you're walking down the curb and you're not really paying attention, your foot slips off and goes this way. Women say this is also what happens when they have heel breaks. It goes this way. I guess, I don't know. Okay. Now, when it comes to learning the muscles, terribly difficult. There's only 700 you need to know. Hey, does everybody have their homework finished?
Yeah.
Good. Make sure your name is on it. And when you leave on break, this next break, just leave it on the table. Here's our cadaver. Okay. The muscles that you need to know, we're going to start with the head. The first ones we see here are the frontalis muscles. And what's the name of the bone that they're sitting on top of? That's the frontal bone. So the frontalis muscles are on the frontal bone. You see how easy that is? And when these muscles contract, if you look at them, you can see them going in this direction. The lines are going in this direction. So we know that it's going to become shorter this way as compared to this way. So when these muscles contract, one of two things are going to happen, because one part is going to be the origin, one part is going to be the insertion, one part is going to move more, one part is going to move less. When these muscles contract, do you think the scalp comes down this way or the eyebrows go up this way? Eyebrows go up, and you know that because I wrote it in the notes. But also because you yourself know that you can't do anything that makes your scalp go this way, but you can definitely make your eyebrows go this way. What's next? The temporalis muscle. That's what I'm going to lateral do. The temporalis muscle is one of the three main muscles involved in closing the mouth. I'm going to sort it down one more time so I want you to see where it inserts. The temporalis muscle, along with the masseter and the medial pterygoid, are the three main muscles involved in closing the mouth. Now, you'll notice if you look here, medial pterygoid. Pterygoid is actually spelled with a P, but it is silent. And you see this a lot in medicine. If you see a P followed by another consonant, the P is silent. So the temporalis muscle, not surprisingly, starts and attaches over here on the temporal bone. And it inserts on the only movable bone in the cranium, the mandible. And you can see how when these muscles contract, it's going to pull the mandible this way. So we know that this is one of the three main muscles involved in closing the mouth. The masseter, the medial pterygoid, and the temporalis. The lateral pterygoid is one of the muscles involved in opening the mouth. These three are involved in closing the mouth. The lateral pterygoid is one of the muscles involved in opening the mouth. And we don't need a lot of muscle, a lot of strength to open. We need the strength to bite down. So you can imagine you're taking a bite out of an apple. You don't have to have a lot of strength to open your mouth to get your mouth around the apple. You just need the strength of really crunching through it. I think I've included in here that these are all innervated by the same nerve, the trigeminal nerve, cranial nerve 5, yes. No, also, I do kind of want you to remember that the temporalis muscle is one of the muscles involved in closing the mouth. It would be nice if you remembered masseter and medial pterygoid also, but it's not totally necessary. The fact that they're all innervated by the trigeminal nerve, cranial nerve 5, is not really necessary right now. We'll talk more about that later on. But that's just sort of a FYI. Go back to the front. Orbicularis oculi muscles are the ones around the eyes. These have nothing to do with moving the eyeball themselves. Those are different muscles. We have actual muscles that are attached to the eyeballs that move the eyeballs. They can go side to side, up and down. These are muscles of the face, so they're around the eye. And these are really going to be involved in things like squinting. I know, terribly important. Orbicularis orbis. These are around the lips. And these are the ones that make that kissy face. Thank you very much. Make you conjure up face. That's nice. I'm blushing. Very, very simple. Orbicularis oculi around the eyes, orbicularis orbis around the lips. What else do I want you to know? We have platysma. Oh no. Oh bloody hell, no. very important one. This one right here. Look at this muscle. This long muscle right here. There's one here, and there's one here. Two places where it starts. One place where it inserts. This is called the sternocleidomastoid muscle. Clavicle, mastoid process. Sternocleidomastoid. So if I were you, I would be at home looking in the mirror going sternocleidomastoid, sternocleidomastoid, sternocleidomastoid. What this muscle is going to do is it's going to bring the head back to center and down just a little bit. So if I'm looking over to my left this way, my right sternocleidomastoid muscle is going to contract and pull my head back to center and down just a little bit.
Why down?
I'm sorry.
Why is it going down?
Only because the origins are down in the front. So it just brings it back down just a little bit like this. So again, if I'm looking this way, I need to bring my head back this way. And those muscles are going to pull it. Sternocleidomastoid muscle is going to contract, so it's going to pull it, so my head goes back like this. And then because they're located down here, it just brings the head back down just a little bit this way. We have other muscles. The platysma is one muscle that's going to help to bring the chin down to the
Is
chest.
that the one in the middle right here?
No, you can't see it. That's the platysma. Very thin muscle, starts up under the chin, and actually attaches down on the clavicle, onto the chest, in fact. And you can see when this contracts, it's going to help open the mouth a little bit, but it's also going to help bring that chin down to the chest. Very, very thin muscle.
That one, the flat one you was talking about, that he in the skull and.
No, that was, when I was talking about the flat, I was talking about the aponeuroses, actually. This right here, this white bunch of tissue. I'll show you very, very quickly, and then we'll take a break here. Okay, here's the abdomen. You see all that? This is all aponeuroses. This is a bunch of very flat tendons that are interwoven that allow these muscles someplace to insert. Same with this side. So we see it a lot of it here on the abdomen, on the skull, on the lower back, behind the knees.
When we seen that live cadaver, was that when we saw it when they cut the abdomen? And there was that line that was over it, when he went to take the abdomen skin out? And then underneath that was the intestines and the stomach and all that. Was this that part?
Well, I don't know. I don't know if you're thinking of the, I don't want to say it, because I don't know if you're thinking of the omentum. The omentum was a yellow fatty pad
Okay, maybe that's what it was.
that was hanging off the stomach, that was underneath, it covers the intestines and
This is
everything
on
like
top of
that.
that?
This is on top of that.
Okay.
You gotta cut through this in order to get to the next part. The next part, in order to get deeper. Speaking of the next part, is anyone not signed in? No? Okay. We'll take a break. When you take a break, please come up and drop off that homework assignment here, please. There's crackers on. I was eating in my classroom.
I wasn't eating, I promise you.
No, we-
Not like I seen that blood in the hallway, I won't do it. Seriously.
All right, moving on to the muscles of the shoulder. Secondary muscles when you're trying to make a big milkshake go small. You know, you shake this up and- Shoulders, chest, and back. The deltoid muscle is an important one for you to know. The deltoid muscle is the muscle right up here of the shoulder. This muscle right here is the deltoid muscle. This is the muscle they're going to give you that flu shot into, or when you're giving flu shots. goes with that muscle. Now remember, what you have to do is find the acromion. You're gonna go about 2 fingers beneath the acromion. From there, I go about 1.5. My fingers are bigger, but about 2 fingers below that, and that creates the top border of your injection site. Deltoid muscle is the muscle that moves the arm up and away from the body. The deltoid also moves the arm up and away from the body. The pectoralis major muscle right here is the big chest muscle. This is the muscle that you use when you're pushing a door open, or you're doing push-ups, pushing somebody away from you.
Is that why they call it text?
That's why they call that pecs, because nobody wants to say pectoralis major, that's too much. But if there's a pectoralis major muscle, then there must be a pectoralis minor muscle. And you can see it right there. The little one right there. Oh, that. Yes. The next one of my favorite muscles here. Because when you slow cook these and cover them in a barbecue sauce or spicy barbecue sauce, they are delicious. They are called the intercostal muscles. And these are the muscles that you find in between these bones here, in between the rib bone. So when you're eating ribs, you don't actually eat ribs, right? You don't actually eat the bone, that's the rib. You eat the muscle around the meat. What do you think meat is?
I don't know, I couldn't, if you were telling me, here go your muscle, I wouldn't.
That's what meat is. Whether it's steak, it's muscle. If it's hamburger, that's just ground up steak, which is muscle. So that's what you're eating when you eat the meat. So the intercostal muscles, you now understand, are delicious when you slow cook them and cover them in a spicy barbecue sauce. They are delicious, and that is a true statement.
So the gristle is
Look at that.
no, I like you in that.
I'll be smart.
So what happens when these muscles contract? Well, they become shorter, but look up here, not down there. Look up here, not down there. Look up here, not down there. When these muscles that are attached to this bone and this bone, when the muscle in between here contracts, it's going to pull these 2 bones closer together. At the same time, the muscle between here is contracting, pulling these 2 closer. At the same time, these here, which makes this entire thoracic cavity smaller. Which means the stuff that's inside of there, it takes up most of the space, is going to get smashed. And what big organs take up most of the space inside of here? Inside of here.
The lung.
So when this area gets contracted and smashed, it smashes those lungs, which forces air out. And we can call that, for instance, a cough. Because when we cough, we're coughing to get something out of the way, out of the airway. And in order to do that, we have to forcefully expel air. And one of the things that helps us forcefully expel the air is contracting those muscles. Now, what happens when you help your friends move over the weekend? They're moving from an apartment to a house, house to house.
Pain.
You feel pain the next day, right?
Yes.
Because you're using all those muscles that you don't usually use to move all that furniture around and to balance it and to fit it through a doorway. Now imagine if you have a really bad cold and you've been coughing for 3 days straight. You ever have that feeling right here in your chest? And the doctor will call that skeletal muscle pain, because you're using all of those muscles a whole lot, trying to forcefully expel air, a lot more than you usually would. And they ache. And of course, we also have other muscles back here that are going to be assisting, called accessory muscles. So we'll see the intercostal muscles a little bit better next slide. You can kind of see them over here, in between the ribs.
Hey, I'm about to say, did you make this one or did I miss it?
Wait, what?
Did I miss this one with your muscle with the sheep? I was gonna miss it. The rest of this is like.
I would like to order some intercostal muscles.
Right. Oh, all right.
Of the cow.
Everything I say in this room is important. You realize that, right? So if you miss one sentence,
I did. Sorry.
you missed the world. All
Ah.
right, maybe not that much, but
I get it, the sheep.
okay. The trapezius muscle, I call this the fun muscle. It's the fun muscle because it's right here. The trapezius muscle. And what will happen is people will ask you if you've studied anatomy, and you'll say yes. And they'll ask you, did you learn the muscles? And you'll say yes. Dr. Sturgeon teach you about the trapezius muscle. You'll say yes. And then they'll ask you, well, then what does the trapezius muscle do? And you'll go, and they'll say, I thought you knew what it does. And you'll say, I do know what it does. And they'll say, well, then what's it do? And you go, 5 minutes of fun right there.
They cause you pain in your parents.
Trapezius muscle, it's going to shrug the shoulders.
Parents grab that muscle, lift the muscle right there, grab and sit.
Don't grab muscles. The latissimus dorsi muscle, you can see a little bit of it right here. Turn them around so you can see a little bit better in the back. It's this muscle here that is going to be assisting
Digital real stuff.
in pulling things towards you. Rowing a boat, pulling the door shut, pulling yourself up, doing chin-ups, pulling something down towards you. Latissimus dorsi, and of course people call this the lats because nobody wants to say the full word.
Show me where we're at.
Here,
We're
latissimus
in the
dorsi.
beginning, right there.
All the way
All the
big.
way.
It's the big back muscle right here, gives the bodybuilders that.
That's the machine I'm using. It's the one you go like this and you pull down.
Yes! That's the machine you're
The fat
using.
rolls in the back.
So how do we move those muscles right there?
Again, remember, you cannot target fat loss. You can only target muscle growth.
Yes.
So it's not going to decrease the fat in that area, but it will increase the muscle tone in that area. But again,
What you said? Forgot what you said. You know, when you work out with the muscles help burn.
yes, and that's what I was getting to
So I gotta
next.
shut my boots
So
off.
when you're working your muscles, you are going to be burning fat, but you're not going to be targeting fat areas.
Yes. For burning fat.
Burning fat overall, yes. And the muscles have to do it. In fact, the bigger the muscle, the more fat is going to be burnt. The more, I should say it this way, the more fuel is going to be used.
Yes.
So that will eventually interpret into some fat loss.
More than cardio.
So the more,
Or no?
not really, no, you want to do both.
Both.
But the bigger muscles that you use, the more it's going to help. So that's why you want to, also target the big muscle that we'll see in just a little bit. So let's go back to here. The upper extremities, the bicep brachii is right here. And you can see that's going to come down and attach to the elbow, right? It's going to attach in the radius over here. And it's the bicep because it has two places where it starts. See here, how it splits? Now, it looks like it attaches at the top of the humerus, but it does not. And if you look at the humerus, there's a groove right here where the tendon sits in. But it actually goes up underneath the sheath and attaches to the scapula over there. But look at this one. Look where this one attaches. Watch right here. Don't take your eyes off of this spot as I strip this away, and you'll see that attachment. Do you recognize that?
Oh, that's it.
Got a little bent finger on the scapula. And here you can see the groove where the other tendon from the bicep comes up and attaches to the scapula here. Bent finger is called what? Coracoid process. So that's the muscle that's going to flex the arm. The opposite one on the other side is the tricep. The tricep brachii, which has 3 places for insert. It's not as obvious here. But this is the tricep brachii. It has 3 places where it starts. And it's going to extend. Extend the arm. Back around again. Okay, this one, please listen. I'm not going to test you on this one. I want you to hear it very quickly. This one right here, the brachioradialis. I wanted to include one of the muscles of the forearms, because we have a lot of extensor muscles here, or flexor muscles here, excuse me, a lot of flexor muscles here. But the one I wanted to include was the brachioradialis. This is the big one that's right here. And it really helps with doing this with the arm. But again, I'm not really going to test you on that one. However, the next ones, I want you to kind of know a little bit. I do want you to know this group. There's a group of muscles right here in the thumb. See this pad? There's a group of muscles right here. There's also another group here, but these are the ones I want you to know right where the thumb is. And they are called the thenar muscles. See this? This group of muscles right here are called the thenar muscles, and they're the ones that are going to help give the grip to that thumb. The thenar muscles. So when you think of the thenar muscles, think of your thumb. When you think of your thenar muscles, think of your thumb. When you think of thenars, think of thumb. Thenars, think thumb. Thenars, think thumb. Got it? Thenars, think thumb. These are the hypothenars over here that you don't need to know this. Just know these. Thenars, think thumb. Now you can look and see here. Here's the brachioradialis. Here are the flexor muscles. Here's the palmaris longus. You can see the retinaculum is here. That's that band that goes around the wrist. The palmaris longus is the only one that goes on top of it. The reason why the fingertips are left on when we prosect is because the tendons go all the way up to the tips of the fingers. So if we were to take the fingertips off, what would happen is all of those tendons would just sort of flop all over the place. So you wouldn't be able to tell which one goes where. See that? And they stretch all the way up to each individual fingertip. And you'll be able to see the retinaculum on the back a little bit better. See it right here?
That's his real body, Dr. Sturgeon.
I'm sorry?
That's his real body.
Yes. So these are the extensor tendons here, the extensor muscles. They're going to extend the fingers. Okay, let's look at the abdomen. Go back to here. One thing I'm going to point out, a couple things I'm going to point out very quickly. Obviously a male, this opening right here, this is called the inguinal canal. And this is the spermatic cord. This goes all the way down into the scrotum and is attached to each testes in the scrotum. So in that cord, bundled up, is blood flow going down, blood flow, venous blood flow coming back, nerves going down and back, and the vas deferens that brings the sperm, it's going to be part of the ejaculate, up in through here, behind the urinary bladder, and then into the prostate, into the urethra. Behind the bladder and the seminal vesicles, and the prostate and the urethra.
So it's only like one tube that it comes out of, like the urine and that
That's in the urethra.
urethra.
That's
Yeah.
in the penis, yeah. That's the one tube. These are the tubes that are carrying stuff to the testes and then back from the testes as well.
What is it called again?
This is the spermatic cord, this is the inguinal canal. That should kind of make sense to you, right? Inguinal region. This is also an area that's supposed to tighten up after the testes come through, about a month before birth. Testes come through, descend down to the scrotum. And then this area should tighten up around that too. Not close off completely, but tighten up around it. If a loop of intestine slips down through here, it will go into the scrotum. That's what we call an inguinal hernia. And we'll talk about hernias later on as well. Okay, here we see all the aponeuroses in the abdomen. Here we see external oblique abdominal muscles. Oblique means at an angle. And you can see them coming at an angle. Now, why do we call these the external abdominal oblique muscles? That would make sense, wouldn't it? And if we take this away, if we cut this away and strip this back, now we have these oblique muscles that are going at an angle, but they're going at a different angle, and they're internal, they're deeper. So we have external abdominal obliques going this way, internal abdominal obliques going this way, and then we have these muscles here. These are the rectus abdominis muscles. The term rectus means straight. And look at the direction these are going. They're going straight up and down. So again, when they were coming up for names for these muscles, they looked at them and said, let's call these the straight muscles of the abdomen. That's all they did. Rectus abdominis. And actually, if we cut away more, we'll see underneath there's even transverse muscles. Now, why do we have muscle going in all this different direction? Because we want to be able to move in multiple different directions. If they only went straight up and down, they would only contract that way. We'd only be able to bend this way, or if we're lying down, we'd only be able to bend our legs straight up. We wouldn't be able to bend to the side, and the back, and turn around, and twist, and put our left foot in and take our left foot out. We wouldn't have that ability. So we have to have the muscle going in all these different directions. Now, if you've ever wondered why they used to do cesarean deliveries this way, because it's easier to cut in the direction of the muscle, because the muscle is going to heal better if you cut this way than if you cut this way. It'll have it be very difficult for it to heal if you cut through muscle this way. So what they used to do when they do a cesarean delivery, they would cut through the skin and everything, or right down through here. Well, here's the thing. They still cut through the fascia and the muscle layers this way, but the initial opening is the phenostele, the bikini line cut here. That's just through the skin. But once you get inside, we have to go in the direction again like this. Prettier looking afterwards, yes. Yes, thank you. I'll look at these muscles right here. Wait, come on. There we go. Look at these muscles. Don't those look delicious? Well, if you were to slow cook them and cover them in barbecue sauce, okay, there are pig muscles. Would they look delicious?
No.
Yes, they do. These are the intercostal muscles.
Cut up already.
All right, here we go. Get ready for this. We're going lower. We're going to start with the lower extremities in the front. Yeah. And we are going to cut away here. And what we're going to see is a big group of muscles here, not this one, but a big group of muscles here. And these are the muscles that you're going to be contracting. They're going to do this. They're going to do this. Now you'll notice they're called the quadriceps femoris muscles. There are 4 muscles. In the parentheses here, I have the names of each individual muscle. Rectus femoris. What do you think femoris means? Femur. And rectus means? Straight. So it goes straight along the femur. And then there's these 3 vastus muscles. Vastus lateralis, vastus intermedius, and vastus medialis. We know that medial means toward the inside, lateralis means out to the side, and intermedius means the middle one. So we have these three other muscles that are on the outside, in the middle, and in the, on the outside, towards the middle, midline, and then one in between those two. You do not need to know the names of these. Rectus femoris, vastus lateralis, vastus intermedius, vastus medialis. I put them there in parentheses. For this class, we can just call those the quadriceps, quadriceps femoris. But I did want you to have the names. And medical assistants, you do need to know about the vastus lateralis muscle. Because when you're giving those children their pediatric injections, that's the muscle that you're sticking. You know, you give young kids vaccinations, you stick them in the leg, but you're not just randomly sticking them anywhere. You're going to stick them in that vastus lateralis muscle. And then we have the longest muscle in the body, the sartorius muscle. Sartorius muscle starts up here and ends down here. And that causes the leg to do this. So if you're playing soccer or dancing a jig, actually it's pretty important if you think about in our ancestry, trying to climb a tree, trying to climb a rock face, you have to be able to get your leg up to that next spot. So that's what the sartorius muscle does. Sometimes called the tailor's muscle, because when a tailor measures a man for pants, you get the diameter of the thigh, they measure from here to here, so it just happens to run right across it. That's all I need to know about that. The tibialis anterior, I only included this, I'm not going to test you on it, but I want you to hear it. One of the muscles in the lower leg, and again, tibialis anterior is in the front of the tibia. You see how this is not terribly difficult? You see how knowing the bones certainly helps? I know. All right, let's go the posterior. And we see the big old butt muscle. Gluteus maximus. This muscle is going to assist in rising from a squatting position and in running. The gluteus maximus is a big muscle, man. So this is a good one to work because you know if you're working this muscle, you're going to be burning off a lot of extra fuel too. Gluteus maximus. Now, if it's the maximus, then there must be a minimus, and there is, in fact, there's others as well. This is actually not the muscle you inject in. You actually inject into the gluteus medius on off to the side a little bit more. It's more over here. And people think they're getting an injection into their butt rather than their shoulder. The muscle down here, it's actually going to the gluteus medius, not to this one. Then we have these three big muscles back here, the hamstrings. They are going to do this. Flex the leg. And they are, again, listed there in parentheses, I believe, in italics. Biceps femoris, semitendinous, and semimembranous. You don't need to know those names, but they're there for you. Moving on down. There's actually two muscles that make up the calf muscle. Soleus, and then this one here that I want you to know, the gastrocnemius. Notice the C in there, this is not gastro like stomach, this is gastroc. Gastrocnemius muscle. This muscle plantar flexes the foot. So if I plantar flex my feet, it pushes me up onto my tippy toes. The gastrocnemius. You don't have to pronounce the C, I'm pronouncing it now, so you know that it's there, so you don't get confused with stomach. You don't see gastro and think, well, that has to do with the stomach. This is gastroc. And notice where the tendon of the gastrocnemius muscle inserts onto the big heel bone of the foot. What is that big heel bone called? Calcaneus. And you can feel this right here. You can put your fingers around that tendon. People call that the Achilles tendon. Have you heard of that? That's what that is. The Achilles tendon. And it makes sense if you think about the foot pivoting. When that muscle contracts, it's going to pull up, so if it pulls up on the heel, the toes are going to go down. And if you've heard of the Achilles tendon, you know it was named after Greek mythology, Achilles. He was, I think his dad was mortal, his mother was a force nymph.
What's that?
Like a fairy. And she wanted to make her son Achilles immortal by dipping him in the river Styx.
Yeah, but she forgot.
Because by coating his body with the water, it would cause the arrows of his enemies to miss or bounce off of him. And so she had to dip him in, but she had to hold him from some area. And the areas that she chose to hold him, that little area by the heel. So when she dipped him in the water, those are the only areas that were not touched by the water. Therefore, those are the only areas that he could be injured. Eventually, someone shot an arrow. I think it was Paris of Troy, not to be confused with Paris of Hilton. Shot an arrow, and that arrow, with a little bit of help from one of the goddesses, guided it to just the right spot and hit him in that spot where he was vulnerable, and he died. Now, you don't need to know Greek mythology for this course. I just threw that in there. But that is how it got its name. And that's why we talk about somebody's Achilles heel, we mean their weak spot, their weakness. Yes.
When your Achilles tendon, if it was cut, a patient's,
Okay.
what its natural feel like?
Well, if it was cut all the way through, there would be some separation because it's always under tension. All muscles are always under a little bit of tension. So it would definitely separate. And I know people all heard about these things. They hear about people going around cutting Achilles tendons. First of all, you gotta saw through it a little bit. First of all, it's not an easy thing to slice through. And then they think, well, then you wouldn't be able to walk. Actually, you just wouldn't be able to walk normally. You would still be able to shuffle your feet. It would be painful, but you would still be able to do it. But it makes a good horror movie. Okay, so what do you think? You got some of these? Here's the tendon right down here. Okay. I'll show you a couple of things very quickly. First of all, I want to show you this. Levator labii superioris aliquae nasi muscle. There it is. Levator labii superioris aliquae nasi muscle. This Levator labii superioris aliquae nasi muscle. This is the longest named muscle in the body, also known as the Elvis muscle, and it does this. Like you. Like you. Thank you very much. You know when you don't like somebody?
That's the longest name, the shortest body.
It's not the shortest muscle, but it is a very, very short
And it
muscle.
doesn't
Compared to.
This is what it does. Levator labii superioris aliquae nasi muscle. So if you're ever on Jeopardy or Who Wants to Be a Millionaire, now you know, they ask you what is the longest named muscle in the body.
I'm gonna just say.
Levator labii superioris aliquae nasi muscle, or Elvis muscle.
They don't even have it in the book.
What bone is this?
Which one? One of the rock?
The one the arrow is sitting
The
upon.
humerus. The humerus.
Why?
Because
So when this muscle cell shortens, all these other muscle cells shorten. This whole bundle of muscle cells, called a fascicle, shortens. All the bundles of fascicles shorten into what's called a muscle here, and the whole muscle shortens.
A muscle fiber consists of a single elongated cell surrounded by a plasma membrane known as the sarcolemma. Each muscle fiber contains multiple nuclei that are found just beneath the sarcolemma. Thread-like structures called myofibrils extend the length of the fiber and dominate its interior. Myofibrils, which are unique to muscle, are composed of two kinds of protein filaments, actin or thin myofilaments, and myosin or thick myofilaments. The actin and
These things here, you see these lines, the lines going this way, the lines going this way, the zigzag line going this way, the lines going this way. When you look at this slice of muscle under a microscope, this is what makes up those stripes, those striations. And we will see in just a little bit how these work. But you'll notice that there's a purple zigzag line here. There's a purple zigzag line here. That is this zigzag line and this zigzag line, for instance. What's going to happen is these little tiny actin filaments are going to get pulled this way. These little tiny actin filaments are going to get pulled this way, so they're going to meet right here in the middle. Are you watching this?
Yeah.
What that means is that this purple line is going to get pulled this way. This purple line is going to get pulled this way. This area here is going to get pulled this way. This area here is going to get pulled this way. This area is also going to get pulled this way. This area is going to get pulled this way, which means that whole cell is going to shorten, which means all those cells all bundled together, that group called fascicles is going to shorten. All those fascicles that are all bundled together in a muscle means the whole muscle is going to shorten. But all that shortening happens right here. Thousands of times over, all in the same direction.
myosin myofilaments are organized in an orderly contractile unit called a sarcomere. The sliding of these filaments along each other shortens the sarcomere. When multiplied millions of times within a muscle, the shortened sarcomeres result in muscle contraction and ultimately movement of the skeleton.
That is called the sliding filament theory. And we'll see some of that. But first, we're getting to.
The coffee is spilling.
Yes?
When we get tested on this, is it gonna be like a picture of the body with arrows pointing at the
No.
muscles?
Good question, actually. No, I want you to know where the muscles are and what they do as to how they're described.
So it's like what's actually written on here is what you want us to know.
Yes. The reason I don't do it the other way is because it's difficult to draw out each individual muscle, and without having all the other muscles around, it makes it a little more confusing. It would be a little bit easier if I was able to pull up something like that and stick a tag on an area and say, okay, now what muscle is that? That would be the better option. But when it comes to taking a test in a class like this, it isn't very helpful. If we had a lab portion of this class, I would have a lab exam specifically on muscles where you just had to identify where they are. You wouldn't have to, like the names of them, you wouldn't have to identify what they do. But unfortunately, we don't have that option. So, for this test, if I ask you what muscle plantar flexes the foot and the toes, you have to know that plantar flexing, first of all, means the toes are going this way down. And then you're going to have to know what muscle does that. So in this case, of course, it's the gastrocnemius muscle, calf muscle, gastrocnemius. The main calf muscle, there's another one there, the soul is, but the one I want you to know is the gastrocnemius. Now, in your notes, if you happen to have those in front of you, remember, you don't have to have those notes. They aren't necessary for your success in this course. You have a couple of things. An image looks something like this. Where you see the end of the neurons, the end of the nerves. Nerves play an important part in muscle contraction because they have to be told to contract. Whether they're voluntary or involuntary, well, most involuntary will need it as well, but let's stick with what we are talking about in this class, the skeletal muscle. All these muscles that you think about moving, they have to get a signal. They have to be told to contract. They have to be told that it's time for them to contract, which means a nerve has to tell them to contract. So here we have the ends of the neurons here. Here's the muscle. So this part in between, not surprisingly, we'd call the neuromuscular junction. And I'm making it with some space in between, but the reality is these are so close together that even under an electron microscope, they look like they're touching, or really, really close. But I draw some space, and you kind of see what's happening here. And we'll do a little off to the side. What is that? Here's a quick demonstration of the sliding filament theory. Okay, so here's what happens. A signal has to come down the neuron, down the nerve, make a lightning bolt, because this comes down very fast in the form of what we call an action potential, which is just another way of saying an electrical message. And we do an electrical message because electric moves very, very quickly. So we have an electrical message that comes down the end of the neuron, but when it gets to the end of the neuron, it has to change into a chemical message. So we have these chemical messages waiting here at the end of the neuron to be released. So when this signal comes down, it gets to the end, we have a calcium channel. So now this signal comes down and activates the calcium channel. Calcium can move in. That's just a signal to release this chemical signal across this space. And it really floods the space. This is called a, well, this official, this specifically is called acetylcholine. I'm going to write that down in just a second. If you're copying this, again, please make sure you're putting all the dots in the exact same place.
This little paper.
All the dots are?
Yeah.
Oh, then,
The
okay.
exact same place too.
Is it?
Yeah.
I'm surprised about that. This is called acetylcholine. This is the chemical message that gets released from the neurons, crosses the space, and then binds to receptors on the muscle fiber. These are receptors. When acetylcholine binds to the receptors on the muscle fiber, what happens is it changes the permeability. It allows something to come inside. In this case, sodium is going to come inside. And remember what I told you, when things go into or out of a cell, the inside becomes different, something's going to happen. Inside of here, we have calcium. Calcium, the Ca++. There's calcium. Stop it.
No, I don't.
Don't. Okay. When the sodium comes in, the inside of the cell becomes different. We have a storage locker of calcium inside of the muscle cell. When the sodium comes in, the inside becomes different. That releases the calcium that is inside the storage compartment So now the calcium that was inside the storage compartment released in here now fills the inside of the cell. That causes these thin filaments, the actin, to slide across the thick filaments, the myosin, bringing all those cells together, closer together, the whole fascicle smaller, the whole muscle smaller. That causes contraction. Easy, right?
No. I haven't even heard about this.
I'm going to go through it again.
Okay.
When a muscle needs to contract, it's going to get a signal from a nerve. The signal in the nerve is going to come down in the form of an electrical message. It's going to come down very, very quickly, very, very fast. When it gets to the end of the neuron, that activates that calcium channel that allows calcium to come into the end of the neuron. That calcium coming in releases the chemical message, which gets flooded across this space. That acetylcholine that floods across the space activates receptors on the muscle fiber. And it activates those receptors that allow sodium to come in. As sodium comes in, that allows the calcium that's stored in here to be released inside of the cell. That causes those thin filaments to slide across the thick filaments, and everything contracts.
Got it.
Well, there's one more thing. Then we have a guy named choline esterase, and he's a recycler. He'll take this stuff and recycle extra, or once it's used, back up into the neurons.
Why didn't draw him on paper? I'm drawing him.
Now, realize how fast this happens. An electrical signal comes down a nerve. When it gets to the end of the neuron, the end of the nerve, that causes calcium channels to open up. Calcium comes in. When calcium comes in, that causes the release of acetylcholine. The release of acetylcholine across the space binds to all those receptors. That allows sodium to come in. Sodium comes in. That releases the intracellular storage of calcium. That calcium then floods that space. That causes the actin filaments to slide across the myosin filaments. Meanwhile, choline esterase is recycling and cleaning up.
Oh, shark man.
Sort of. Dante, how fast is this happening? Dante, how fast is this happening?
Not fast.
How many muscles did he just have to use in order to almost catch the markers? Not 700 of them.
No.
Did he have to move his arm? Did he
Yeah.
have to move his hand? Did he have to open his fingers? Did he have to close his fingers? Did he have to bring his fingers this way? Did he have to shift his body a little bit? Were his eyeballs tracking as it was going across the space? All of those muscles that were contracting and relaxing and doing all of this, all of them went through that cycle of the signal coming down the nerve, causing the calcium channels to allow calcium to come in, which causes the acetylcholine to get released across the space, which causes all those receptors to get activated, which causes sodium to come into the cell, which causes the intracellular release of calcium, which causes the actin filaments to slide across the myosin filaments, which causes the muscle to contract. All that fast. I don't really catch that.
Sorry.
All that fast. That's a lot of, no, I'm just kidding. Just one catch. That's a lot. So I mean, imagine catching these when they're, when you actually have to put a lot of movement into it. And you'll find out that our bodies, our muscles, are always in a partial state of contraction. Why is that, Dante? Why are our muscles always in a partial state of contraction? Because you never know when markers are going to come flying at you.
Right.
They always got to be a little bit prepared. Does that make sense? Okay, thanks. Edit that out. Thank you. We'll go over more of this in just a little bit. I'm going to get a cup of coffee and we'll take a break. Together all in the same direction, make muscle fascicles. Then we put a bunch of muscle fascicles all in the same direction. you get a muscle. Acetylcholine is internal axon, that's the end of the neuron, the end of the nerve, across the neuromuscular junction, binds receptors on the muscle fiber, the change, allow sodium to come into the muscle, which is then going to release the intracellular stored calcium. The sliding filament theory is then when we see those actin filaments sliding across the myosin filament. That's going to cause everything to shorten. We call that a contraction. Then we have our friend cholinesterase who's going to do some recycling and cleanup. He's going to put back extra and he's going to recycle what was used so that it can be released again. And muscles are always in a partial state of contraction, always getting a bit of a signal. So if we have a whole lot of acetylcholine coming from here, which means a whole lot of signal coming down the neurons, and a whole lot of binding that happens here. A whole lot of binding means a whole lot of sodium coming in. It's calcium being released. It's a very strong contraction. A little bit of binding, a little bit of sodium, a little bit of contraction. Meaning sliding filaments. Interesting thing about the sliding filaments, as the actin gets pulled this way and this actin gets pulled this way, in order to pull, it has to then release, to pull again, to release, to pull again, and to release. In order to release that grip and eventually relax the muscle, we have to have something called adenosine triphosphate, also known as ATP or energy, what we use, right? Well, here's the thing that happens. How do we make ATP?
Glucose.
We're going to need some glucose. What else? Some water, and what else? Oxygen. So, when a person dies, are they going to have blood pumping around?
No.
Are they going to be delivering glucose, oxygen, and water?
No.
So these muscle cells are going to get any glucose, oxygen, and water? So when somebody dies, this stuff isn't getting the fuel that it needs, so the cells start to break down, they start to break apart. Now we get a whole lot of calcium just flooding this cell. Well, isn't that what happens when muscles contract? We get a whole lot of calcium flooding the cell. Which means after they die, no, this is 24, this is all up to 24 hours after they die. What's going to happen is all this calcium is going to be released in here, and the muscles are going to contract. That's what we call rigor mortis. They contract and tighten up like this, but don't relax because there's no energy to allow them to relax. And then about 24, 48 hours later, after the death, the whole rest of the cell starts to break apart, and then gravity just takes over. This is going to help us determine how long somebody has been dead, depending upon whether or not rigor mortis has set in, or has not yet set in, or has already set in and passed. Make sense? Okay. Good. Good. Let me tell you about a disease very quickly. I'm going to skip ahead just for a minute, so just pay attention right now. This is called myasthenia gravis. This is an autoimmune disease. Now, of course, autoimmune means the immune system is making a mistake. It's destroying something that it thinks should be there. Their eyes are going to droop like this, something called ptosis. Not surprisingly spelled with a P, but pronounced ptosis. So if I think this patient has myasthenia gravis, I'm going to give them a test. I'm going to give them an injection of a short-acting cholinesterase inhibitor. What that means is, even though there's same number of receptors are still there, that keeps the acetylcholine in this space longer. This is called everphonium. It's a short-acting cholinesterase inhibitor. So now, even though there's only a few receptors, there's a whole lot of acetylcholine still here, so they're getting bombarded. You will see them within 2 minutes. You'll see their eyes go like this, back to normal. And you'll see they'll be able to walk up the steps and walk down the steps and be just fine. It'll look like a miracle. For about 30 minutes. And then this will start to happen again. All this is a confirmatory test. Now we can give them something longer acting, but the body's going to continue to destroy these. So the next step will be to take out the thymus, which is located right here. Go thymectomy. And that's going to stop making the cells making the antibodies to destroy these. So it's an interesting image of how we can alter what cholinesterase does, I think. We'll see this in other areas of medicine as well, where we can interrupt something in here that's going to allow more or less the receptors to get the chemical message. All right, let's go to pathology. Active atrophy. The first thing we see here is atrophy, also known as muscle wasting. Decrease in the size of the cells or decrease in the number of the cells due to prolonged inactivity or malnutrition. The muscle loses its bulk. Hypertrophy is just the opposite. Enlargement of the muscle. So that's what you think of people who work out a lot, bodybuilders. The term avulsion can be applied in other areas of the body. When we talk about muscle, an avulsion of muscle means muscle tears away from the tendon or tendon tears away from the bone. And in some cases what will happen is the tendon will actually take the bone with it. So you got to reattach the bone to bone with a screw. Needless to say, this is going to be an injury that is going to take a little while to heal. Compartment syndrome is a crushing, blunt injury where the fascia separates from the muscle and blood fills up that space. That's going to put more pressure in that area. It's going to put pressure on the nerves, it's going to put pressure on blood supply, which can cause a lot of pain, which can cause the blood not to flow very well to other areas, which means now we can have an area that can be compromised. So I have to do a fasciotomy and take that blood out of there, drain it. A contracture, this one you've seen before. You ever see somebody their arm is always stuck like this? Well, in order for the arm to be stuck like this, rather than fusing the bones that way, that means the muscle's pulling in that position. Why is the muscle pulling into this position? Because the nerve is constantly sending that signal. Contract, 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 contract. That indicates nerve injury, not muscle injury. Or we'll see something in Erb's palsy called a Wader's tit. This often is seen in a brachial plexus injury, right up here during the birth process. Fibromyalgia, this one's kind of difficult. This one's difficult because I don't really know a whole lot about it. Fibromyalgia, these patients are going to complain of pain in the joints and the muscles, but all over. And the problem with fibromyalgia is this is a diagnosis of exclusion, which means we have to test by doing x-rays, CTs, blood work, muscle testing, nerve testing. When all that other stuff comes back negative, now we can say the patient has fibromyalgia. There's actually a pressure point test. I think we're up to like 18 points. If the person feels pain at like 12 of the 18 points, then we can diagnose it as fibromyalgia. But the reality is we still have to go through that process. And I'll show you why. Just bring on this line, right? If I am a brilliant diagnostician, the best in the top 3 in the world, and Brian comes to me and he says he has these pain in his joints and in his muscles, and I go, well, I just think it's fibromyalgia, just by what he's telling me. And I go just to the pressure point test. I can come over and do this and say, okay, does that hurt? Well, he said, no, that doesn't make sense, because I'm one of the best diagnosticians of the planet, probably top 3. That should have hurt if he really had fibromyalgia. Let me check again. So I do this. I go this, oh, sorry, I go like this. Does this hurt? Ah, see, I was right. My diagnosis was right. Do you see how I changed the outcome of the diagnosis based on how much pressure I put? That's not a good diagnostic test. That's why it's the last thing you do after you test for everything else. Unfortunately, sometimes people will just jump right to the pressure point test. We really don't know what causes it. We know that it also has some sort of psychiatric component, something like depression or anxiety, which is why these patients are usually treated for both. Have you ever heard the term psychosomatic? The brain thinks that the body can feel it. We're not saying the pain's not real, but we're saying it's caused by these other things. Appears to be associated with obesity, anxiety, depression, and social stressors. 7 times more common in women than in men. That's a lot. So we have a lot to learn yet still about fibromyalgia. Hyperextension, hyperflexion injury. Our neck or head suddenly hyperextends too far this way, flexes too far this way, or vice versa. What we call that is whiplash. Now, of course, that can injure muscle, tendon, ligament, bone. We saw that, right? The hangman's fracture, as well as the nerve in the spinal cord that's right there. So we do take those seriously. Contusion is just a fancy name for a bruise. And I mean, the reality is we could put this in any other area, any other section of the body, but I just chose to put it in with the muscle area where there's tissue injury, vessel injury, blood collection. A spasm is what we call a cramp. Listen to my definition. Temporary, doesn't last long, although it seems like it. Sudden, comes out of nowhere. Severe, we know that. Prolonged contraction. Like a Charlie horse. They're horrible. Where do they come from? Well, nowhere. Do they come on fast? Yes. Do they last forever? No. Temporary and sudden, although it feels like it. Is it really, really painful?
Yes.
Severe. Prolonged contraction. Now, what causes that? Dehydration could definitely be a problem. We might have not enough nutrients going to the area. We might have too much waste product build up in the area. So we got to get some more fluid there. Remember, the solution to pollution is dilution. So dehydration could cause that. Too much lactic acid built up. I know not enough other nutrients like potassium. People will say, eat a banana. And that certainly could be the case as well. I'm sorry?
So that means you're gonna go find a banana in the middle of the like.
Hopping around, like, yeah. Yelling out, banana, 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 banana. Looking incredibly foolish. Cat staring at you, which is really weird because you don't have a cat. And that just makes it a bad, bad day. Yes.
Okay, so I'm not gonna get on the detail. Certain times I get a Charlie horse and I know I'm gonna get it when I'm doing a certain thing. How come this happens? No, I'm serious. No, I know it's gonna happen. Alright. No, it's almost 9 times out of 10 it happens, but I'm just saying, like. That's why I said attention when he said that, but he said it was dehydration, so maybe if I drink water before.
He's trying not to smile.
I'm serious though, if I drink some water before this activity,
Okay.
I might
Please stop. Just please stop. Everyone now knows.
No, but look, it's right here.
I know where it is, yeah.
Alright. So it always happens though, so
Sometimes this can occur as a result of overstretching the muscle a little bit. This is why you don't want to stretch like before you go to bed. You don't want to like exercise like before you go to bed. You want to make sure you're hydrated. You know, and the more muscles used, the more blood flow goes to the area. And we see this in other things as well. Anybody eat chicken?
yes.
Do you like the white meat or the dark meat?
Dark meat.
Like,
What about turkey?
Yeah, salt. I know white people got salt. Salt, they need salt.
Anybody ever eat duck?
Yes. When I was really young, I ate
You like the white meat or the dark meat?
I like the white meat.
If you actually look,
Yeah, I didn't look.
there is no white meat in duck. First of all, didn't anybody ever question, didn't you ever wonder, why is my bird made out of two types of meat? Anybody ever wonder that? No, you didn't care, you just wanted it on your plate. Why is there two types of muscle in those chickens, in those turkeys, but in duck? Yes, absolutely.
Yes.
Have you ever stood outside with your friends and go, hey, look at all those chickens,
Because chickens get fat.
look at all those turkeys?
So the thighs are better because they use those more.
So they have more blood supply going in that area. They have more need for nutrients in that area, like fat,
And that's why it's
which is why dark meat is greasier, which is why duck is greasier all over.
Ew.
It has more blood supply going there, more fat in that area that it's going to use for instant, like almost instant energy. Whereas other areas of their body, like their breasts, the wing, the muscles that would be used to fly, aren't really used as much. So they don't have to have as much blood going. You never really thought, well, this is two different types of meat.
That's why I hate fried meat. So disgusting.
If you ever hear of anybody getting cramps at night, lying in bed, no, listen, stop. Sleeping in bed, getting cramps in their legs. One of the things a person can try to avoid getting cramps to begin with, once it happens, it's too late. But to avoid getting cramps to begin with, is to get a bar of ivory soap and take it out of its wrapper and put it in the sheets down by their feet.
What?
I heard
Get
you.
a bar, okay. That will help decrease the chances of leg cramps occurring at night.
How?
No idea. No clue. This is one of those old wives' tales that might have something to it. There might be actual some merit to it. Now, the mechanism of action, God only knows. Maybe it's an exchange of electrons
From soap.
the protons, too much lactic acid, creating neutrons. No, just put the block, put it down by your feet, that's all. Now, is this gonna work for everybody? No. Because when I have a headache, I take 2 Advil. When she has a headache, she takes 4. When she has a headache, she takes 6. When she has a headache, Advil doesn't touch, she has to go to something else. But it doesn't mean Advil doesn't work. There's enough evidence that indicates that there might actually be something to this, as weird as it sounds. And I mean, the worst case scenario is you get soapy sheets. It's not, it's washable. You don't have to use soap because it's already there. So it's worth trying.
Around the ankle area?
Just down around the ankle foot area.
Just put it in your sock.
And it has to be ivory soap because that's what the
I'm thinking about it, I knew about that because my sister got get cramps a lot. And she's always said, put the bar so and she started getting cramps. Now, I was sick.
testimony.
I know, I just from being a child and being sick, she used to put an onion on
Yeah.
her beans. I thought she I would just smell like onions all day long.
Yeah, that's exactly what happened.
And
I mean,
I kept telling my grandma, that does not work.
It does
Please
not.
stop doing that and I have to walk around smelling like an onion. That is
Yeah.
horrible.
It doesn't-
That doesn't work. I figured that. But
Sorry.
I figured if the soap worked,
I
I
understand,
thought about it if
yes.
I figured the soap.
Well,
like,
Grandma was right about some things.
Yes, she was.
Starve a fever, feed a cold. She was right about that. Onions, no. Cabbage in the bra with breastfeeding.
What?
Or, you ever heard that? Yeah. I mean, the reality is, it's just because it's something cold that comes, you know, it's in a good shape. Exactly, that's exactly why, because it's that cool temperature and just helps to bring some of that extra, stop some of the extra. And the pia mater. The dura mater is the thickest, most outer layer protecting the brain. So if we're going to drill in through here, the first layer we come to is the dura mater. And you can see in some places it even splits off, like where there's this central fissure right here. Beneath that is the arachnoid mater, this layer. The significance of the arachnoid mater, and if you think arachnoid, doesn't that sound like spider? It does, because the area underneath it, the subarachnoid space, looks like spider webs. And this is where the cerebrospinal fluid is going to flow. The cerebrospinal fluid is delivering nutrients everywhere, and this is the area through which it flows, in the subarachnoid space. The pia mater is the thinnest lining around the brain, and as you can see, it is in direct contact with the brain. It's sort of like shrink wrapped, and it goes down and follows all of those sulci, all the way down the bottom, all around the gyri here, those grooves. The blood-brain barrier is important because we have to make sure that things that can be dangerous to those very delicate and sensitive neurons don't come in contact with them. So the body has set up a barrier system so that only some things are allowed to cross over and actually come in contact with the brain. And you can always tell when something crosses into that blood-brain barrier because it's going to have a very similar effect. For instance, Benadryl, diphenhydramine, crosses the blood-brain barrier. And what effect does it have on neurons? Slows them down, and then of course the person goes to sleep, causes drowsiness. Good. Spinal cord, moving right along. Spinal cord. Remember the spinal cord is those branches of nerves that are bundled together, runs down from the medulla oblongata, through the vertebral foramen, all the way down to the lumbar vertebrae. About between the first one and the second one. And that's where it branches off into what looks like a whole bunch of horsetail. As it descends, 31 branches of spinal nerves extend out. So as this spinal cord goes down here, there are branches that come out. And you can see them here, and you can see them here. As soon as this arrow goes where it needs to go. Okay. You see it here, you see it here. Notice how they refer to these. The branches that are in the back, they call the dorsal, and the ones in the front, they call ventral. Rather than using anterior and posterior, this is why I tell people you do need to know that anterior and ventral mean the same thing, and posterior and dorsal mean the same thing. Because you'll hear things like the dorsal root ganglia of the spinal nerve. And that'll make sense if you know that the dorsal root is the one in the back. The dorsal root is going to have messages coming in. The ventral root are going to have messages going out. Now, what messages are going to come in to the spinal cord? Things like sensation, like pain. These are what we call afferent nerves. They're going to be bringing messages in. Something touches your skin. How do you know where it touched your skin? Well, I felt it right there. Well, how did the signal get from here to your brain? Well, eventually, it went from here up to the spinal cord, which then went up to the brain. And that's how you can pinpoint which nerve it came up. So the ones in the back are the afferent nerves coming in, the dorsal are the afferent nerves, and the ventral are the efferent nerves. These are sending signals out, like move your arm, or move your leg, contract that muscle. I will tell you right now, you definitely want to know afferent and efferent. Because these are words, these are terms that come up, not just in the spinal cord, but in other places in the body. Afferent are always the ones going to, efferent are the ones coming from. Second paragraph down, they got little stars next to them. Page 54, if you happen to have the notes in front of you. You don't have to have the notes in front of you. You'll find the same thing in the textbook. In fact, it's on the textbook on page, so you can look there. The center of the spinal cord. You can see right here, it has this H pattern to it, or butterfly shape pattern to it. That is the dark matter. The outer part is the white matter, which is the opposite of what we saw with the brain. It's the same parts, it's just set up the opposite. And of course, just like the brain, we're going to have some layers around here, like the dura mater to protect it, the arachnoid mater underneath that, and the pia mater underneath that, just like the brain. The only difference is there's one extra area around the spinal cord, and that is called the epidural space. And it is within that space that we inject anesthesia, which is going to affect these nerves right here, the dorsal nerves. Which means signals coming in of like pain are going to get blocked from that point down. You see how that works?
But it looks like it's going through the bone.
I'm sorry?
Does the needle go through the bone?
It says between the bones.
And remember, these are separated by a cartilage disc
Yeah.
right in there. Okay, move on. Reflex arc. Reflex arc, you know what this is. This is where you're talking to somebody, you're not paying attention, you put your hand down on the hot stove, and then you do something like this, because it always sort of happens, actually, more like in this order. The reason for that is because as this fingertip touched that hot stove, that signal sent up the arm to the spinal cord. The spinal cord makes a quick decision, not the brain. The spinal cord makes a quick decision that says, let's move that finger away. In fact, let's move the hand and arm away. And just because we don't know what's happening here, let's even move the body away. Then the signal goes up to the brain and says, that was really hot on your middle finger. What did you touch? Which is why you usually see it something like that. There's that hesitation between looking at what happened, because that has to get to your brain first. The first thing you do is you move away, because the signal gets sent up here, around here to the spinal cord, then back down, out of the spinal cord, says, move those muscles, move that side of the body, and then the signal continues up to the brain and says, your middle finger was on fire. What just happened? What that means is when we're testing somebody's reflexes, and they're sitting on the edge of the table, we have a reflex and we're hitting right here, we're not testing their knee, we're testing that arc, which includes their spinal cord. So we're testing how that signal goes up here, transfers around, and back down here again. Because that little thing is involuntary. When you see somebody's leg kick out like that, I'm not thinking I should kick my leg out right like that, because that makes a good dramatic effect. Does that make sense? So we're testing the nerves and the spinal cord, how it works. Okay. On to cranial nerves. Cranial nerves, where does it sound like they come from? Gotta be from the head area, right? Cranial nerves come from the brain area, and they really only work on the head and neck area for the most part. Most of them are just going to do stuff in the head and neck region. And there are 12 cranial nerves, and you'll notice they are Roman numeral. Then they have a name. Then they have what they do, how they function. Are they a motor nerve? In other words, are they going to say, send a signal out and make that muscle move? Are they a sensory nerve? Information comes in, I can taste it. Or are they types of nerves that can do both? That's what I mean by sensory or motor or both. Yes, you need to know these. No, you don't need to know all of them. There's 3 for this chapter that you need to know. Cranial nerve 5, the trigeminal nerve. And you'll notice that it does both. Cranial nerve 7, the facial nerve. And you'll notice that it does both. And then cranial nerve 10, the vagus nerve, the wanderer, which does both. So that's easy enough for you to remember. And we'll talk about these in other chapters as well. But for right now, for the midterm, for this chapter, those are the 3 that you need to know. Notice the vagus nerve actually goes all the way down past the diaphragm into the abdominal pelvic cavity.
Which one's that one?
The vagus nerve, cranial nerve 10. That's why it's called the wanderer, because it's the only one that goes all the way down to there. Most cranial nerves act up around this area. This is the only one that goes down beyond the diaphragm. If you notice, cranial nerve 12, hypoglossal. Initially, I had it as both, but my friend, who I went to medical school with and was looking at my notes, said, "You're wrong. It does not do both. It's a motor nerve." And I said, "I thought it had some sensory component to it." She said, "Well, it might have a little bit." So I said, "I was partly right." She said, "You need to fix that." So that's why I fixed it. It is not both, it is mostly motor, although I still think it has some sensory. Yeah, we got stuff to do, we got stuff to do.
I didn't believe that all the time. I'm sorry.
Whoa, we are not almost done. Parasympathetic nervous system, we talked about that. Sympathetic nervous system, we talked about that. Now, I told you the neurons are the parenchyma, the functional unit of the nervous system, including the brain and spinal cord. However, there are a lot of cells that help out in the nervous system. Nervous system accessory cells. They help out. And the reality is, combined, there's more of them than there are neurons. But here are the ones you need to know. Astrocytes. Astrocytes are large cells with radiating branches. They form the blood-brain barrier. Astrocytes. They form the blood-brain barrier. Here's how I remember astrocytes. They have radiating branches. Makes it sound like, to me, like a star. And astrocyte sounds like asteroid, almost. So I think star, space, okay. So astrocytes, in my head, look like stars. And then, if I get a bunch of astrocytes and I put them like this, then it looks like a fence. It is the fence, the barrier between the blood and the brain. Astrocytes are the cells that make up the blood-brain barrier. That's how I always remember them. Ependymal cells, these are the cells in the ventricles that make cerebrospinal fluid, the CSF. Microglia cells, these are the small cells, micro, but they can gobble up a lot. They're phagocytes. They can gobble up a lot. Then the next two are the oligodendroglial cells and the Schwann cells. Basically, they both do the same thing. They just do it a little differently and in a different place. Watch this. Remember that insulation I said that is on that axon that's all the way down? That insulation is actually made up of a cell or a part of a cell, depending upon the oligodendroglial cell or a Schwann cell. In this case, the Schwann cell wraps its entire self around. This is the job of a cell. All he does is wrap himself around and become insulation. He becomes the myelin. The oligodendroglial cell does sort of the same thing. He wraps part of himself around this one, part of himself around this one, part of himself around this one. But basically still becomes the myelin. The difference that'll make it easy for you to remember right now is where this occurs. So if you can just remember they both do sort of the same thing, the oligodendroglial cell and the Schwann cell, they both become insulation. But where it occurs is important. Oligodendroglial cells do this in the central nervous system. Schwann cells do this in the peripheral nervous system. So if I were you, what I would do, if I didn't understand what's happening, what I would do is I would put Schwann cell on one side of the note card, PNS, peripheral nervous system on the other side. A oligodendroglial cell on one side of the note card, CNS, central nervous system, on that flip side. So even if I didn't totally understand the concept of what's happening, at least I know that Schwann cell, well, that has something to do with the peripheral nervous system. Oligodendroglial cell, well, that's about the central nervous system. And that would help. This is a space in between the node of Ranvier, for those who care. So those are the neuroglial cells that you should know about. I already talked about some neurotransmitters. Endorphins are the body's natural pain relievers, stronger than morphine. Now, we're going to start in pathology, but I don't remember where we're going to start. What's the first thing that we're going to start talking about? Oh, right, amnesia. Thanks for playing. Amnesia. That was so bad. Amnesia is when you don't remember something, right? Do you know amnesia is actually done intentionally by the brain? It's a defense mechanism. So when that person gets in that car accident, goes flying through the windshield, hits the next car head on with their head, their brain says, I don't want to remember that. Let's block that out. That's why it's supposed to happen. Unfortunately, anytime a person gets a blow to the head, they can have some amnesia. Now there's different types of amnesia. There's several different types. Sometimes a person will remember who they are and where they're from, but they don't remember what they had for lunch or what they had for breakfast. Sometimes they'll know exactly what they had for lunch or breakfast, but they have no idea who they are or where they're from, and there's variations in between. If you've ever seen in the movies where the patient's in the bed and the family's there, and they say, doctor, when is our brother going to get his memory back? And the doctors always say the same thing. Well, we'll just have to wait and see. Because the reality is, we have no idea. We don't know if it's going to come back completely, we don't know if it's going to come back all at once, or it's going to come back a little at a time. No idea. So we don't know the brain that well. Okay, man, we are. Anencephaly. This is what anencephaly looks like. What's an mean? A-N. Without. Cephalo is head. These are babies who are born without a brain.
How does that make sense?
No directions. Or you either don't have the directions, or you don't have the products to build it.
They'll die all the time. There's a little boy,
Yes.
he's still alive.
And in fact, the cranium will even be missing. There'll be skin, there'll be hair, but there'll be a big indentation right here. And he always knows where I will go. Now, depending upon how much anencephaly is stripped, it's total, and there's nothing there, these babies aren't going to live. In fact, if they're born alive at all, and I use air quotes, you might be able to they might live for 5 minutes, depending upon how long that the brain stem is there, how much the medulla oblongata is there, keeping everything going. But after a few minutes, even that has to go, okay, now what do we do? Well, there's nobody left to ask. Everything just stops. This is one of the reasons why I still do late-term abortions. Because if a mom's going to have a baby like this, there's no reason to have the baby. You can't fix this. You can't save it. You can't do a brain transplant. You're going to give up your brain to transplant it to a baby? No. We can't. That's unfortunate.
But can't they get like brains ready if they know that the baby's gonna come like that? I'm saying like a brain transplant, like they could cut, his skin open and
From a living person.
Not from a living person. Oh, never mind.
I'll let you get there. Okay, you got it now, right? Awesome. Yeah, we're just not there yet with that kind of technology. We're not going to start doing people's brains away. So this is not common. If you go down to the Modern Museum or the Mutual Museum downtown, they have some nice specimens there. Aphasia, Loss of ability to communicate either in writing or verbally. There's different types of aphasia. I've just included two, expressive and receptive. Expressive aphasia, the patient can think clearly but cannot articulate. So I know exactly what I want to say, and when I try to say it to you, it comes out. Receptive aphasia is when the patient can speak clearly, but when people speak to them, they hear wah, 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 like Charlie Brown teachers.
My son did that.
Brain tumors. Brain tumors are all bad. Doesn't make a difference if they're benign or malignant, because if they're growing, what's going to happen?
Inflammation, pressure.
Is that cranium, that skull, is that going to grow and grow and grow with it?
No, it's hard.
Not in an adult, right? This is solid. But if the tumor inside or anything inside is growing,
Or smush.
it's going to smush the brain. That's what we call space-occupying lesion. That's bad news. So even if it's a benign tumor, if it's growing, there's still a problem. So all brain tumors are bad. Cephalgia, that's a fancy word for a headache. You can say, Dr. Sturgeon gave me such cephalgia today. Cerebral palsy, you've heard of this one, right? I definitely want you to know about cerebral palsy, caused by lack of oxygen parts of the baby's brain and uterus during the birth procedure. Can cause everything from muscle paralysis to spasms, mental retardation, seizures, etc. 80% of the cases of cerebral palsy are caused by things that were unpreventable. They were going to happen. 20% of the time, we didn't know what caused it. Of those 20%, those are the ones that the lawyers try to sue for. Of those 20%, more than 80% of those cases are found in favor of the doctor or hospital. So there's only a small percent, basically 20% of the 20% where it's actually found in favor of the claimant. This next one is an important one also that you need to know about, a cerebrovascular accident. Cerebrovascular accident, also called a CVA, it's what we call a stroke. So there is a disruption in blood flow to an area of the brain. Causes dead tissue, except not in the heart. So then call it a brain attack, because that's basically what's happening. Of course, it's going to take a lot less time, right, for that brain to die. I'm going to go with 20 minutes to see irreversible cell death. All right, here's the one you were asked about before, concussion. Traumatic injury to the brain. Everyone agrees on that?
Yes.
Why? I'm not asking, I'm telling you. Everyone agrees on that. Everyone agrees that a concussion is traumatic injury to the brain. What has always been a debate for a long time is whether or not there has to be any sort of loss of consciousness, even a little bit. Well, that's what I'm saying. It's been a debate for a long time. There still goes back and forth a little bit. That's why if you go online and you read 10 different articles about concussion, some are going to say that there must be a loss of consciousness. Some might, most of them will not. Most will say there doesn't need to be, but there could be. So just understand that you're going to hear both sides. That's why I put that side in there about a loss of consciousness, but most of the time there doesn't have to be. Now, why then do we make sure the patient doesn't fall asleep for a few hours if we suspect a concussion?
They'll slip into a
You
coma.
can't tell, but it's sleep. You can't ask him a question?
Can't ask them a question, you can't see what's happening. What happens if you're talking to them and they're talking to you and telling you the story about what happened and then suddenly they're, then you know something just happened. And if something just happened, we're going to need to correct this quickly or it could get worse. Or maybe suddenly their vision goes. They say they can't see anymore. They can see you right now perfectly and then suddenly the vision just gone. It's called amaurosis fusset. It's called amaurosis fusset, the closing of the curtains. Now, how would we know that was happening if the patient was asleep? We would not. Yes.
when you get in the CAT scan next, or no?
MRI. I'm going to MRI, magnetic resonance imaging.
So what do the CAT scans go to?
This is what the CAT scan looks like. This gives us a slice. Right here. An MRI is more three-dimensional.
Hydrocephalus.
Real, is that?
That's a real start.
Are you sure?
That's Okay, we're not there yet. We're almost there. Hold on, getting closer. Dementia. Disease in the brain in which many neurons die, causing progressive decrease in mental capacity. Although senile dementia is very common, the most common cause of dementia is Alzheimer's disease. Do you understand that those are two different things? Alzheimer's disease causes dementia, but there's other things that can cause dementia. Alzheimer's disease is the result of a bunch of neurofibrillary plaques and tangles that get in a position where they interrupt that signaling from neuron to neuron. Down syndrome, we talked about that. I'm not going to talk about that anymore. Dyslexia, you know what that is. Encephalitis, inflammation of the brain, typically caused by a virus. The most common cause of encephalitis is herpes simplex virus. Most people, when they think of herpes, they don't think of the brain. I do. Because I know that herpes is the most common cause of encephalitis. Inflammation, brain. Epilepsy. Please listen to this. Recurring condition in which a group of neurons in the brain spontaneously sends out electrical impulses in an abnormal, uncontrolled way. This will produce seizures. There are several different types of seizures. I listed two of them here. A tonic-clonic seizure, also known as a grand mal seizure, not a grandma seizure. A grand mal seizure is when grandma has a seizure. This is a grand mal seizure, a tonic-clonic seizure. And it is exactly what you think when you think of somebody having a seizure. Losing consciousness, arms, body parts, flailing about. Please don't put anything in these patients' mouth. They're not going to swallow their tongue. Because in order to swallow their tongue would have to go down the esophagus into their stomach. Which means you have to cut it off, and cut it into smaller bite pieces, and a little hot sauce. They're not going to swallow their tongue. What people mean to say is their tongue's going to block the airway. Well, that's not going to happen either. Don't worry about the tongue blocking the airway. I'm sorry?
They're gonna choke, right? That's
On
they
what?
mean. Their spit, or vomit, if they.
Well, that's the only time you worry about them choking is if they're eating something, or if you can see them vomiting or something like that. Then you can gently roll them onto their side, but otherwise you just control them so they're not hurting themselves. So if their head is banging on the floor, you can keep it from banging.
Yeah.
If their arms are flailing about right next to that box full of rusty razor blades and barbed wire you've been hanging on to, you might want to keep them from hurting themselves. Do not stick anything in their mouth. If you stick a pencil in their mouth to try to stop their tongue, whatever, they could bite the pencil, and that could not swallow, inhale, goes down the airway. Now we have a problem. Don't do that. Some people will say, get a metal spoon, put it in their mouth. They bite down on that, they could break their teeth. Now we have teeth going down into the airway. Now we have a problem. Some people say, put your finger in there. They can bite down on that, and now you have two problems, because that could go down into their airway. Problem number one. Problem number two is now you can't point at things. I want that.
If people can bite through your finger, does your character, your brain does tell you not
I'll try it. I don't know how much bite force it takes to bite through either a carrot or a finger. I don't know. I think that would probably be reasonable to think it's something close to that. Yeah. Don't stick anything in the person's mouth. Make sure they're not choking on anything. if you see something, if you see like they're visibly choking, like on vomit,